stage, you should be very privy to being able to measure certain levels of fertility using the different measures that we were able to discuss. But also, you should be able to understand some of the key causes of fertility, but also causes of infertility. And you should be able to conceptualize Bongard with his proximate determinants of fertility in there. And at this stage of this module, as we summarize it, you should be well versed with the diagnostic measures or some of the diagnostic aspects of reproductive health, because we discussed issues of assisted reproductive technologies, and therefore you should be very versed with those methods of assisted reproductive technology. But also, there's where we tampered with the aspects of ethics regarding the assisted reproductive technologies. And we also were able to look deeply into what those measures mean, but also some of the current trends of infertility in the society and how they impact the society in terms of the social, economic, and environmental aspects. And also, we looked at mainly how the impact of infertility is in terms of in the society, but also in the family itself. So we have broadly covered the aspect of fertility, and today we just want to now look at the aspect of health policy regarding fertility, but mainly we want to look at infertility because, like the trends have shown in our previous lectures, it is actually becoming a double public health problem in developing countries. It's becoming double because whereas developing countries are suffering issues of high population or high fertility rate, at the same time they are also starting to suffer issues of high infertility rate. So it is a double disease burden, just like we are suffering disease burdens of infectious diseases and cardiovascular diseases. And therefore, that is why today we want to look at the aspect of public health policies, but at the same time, we want to focus it directly into infertility, but also mainly into assisted reproductive health technologies. And that is why we're saying here that public health policies play a very crucial role in addressing infertility related issues and ensuring access to treatment. And in assisted reproductive technology, there are mainly three aspects in which we want to look at, and they are the most relevant in the perspective of a health policy. And the first aspect we want to look at, if you're to develop an assisted reproductive technology health policy, the first aspect we want to understand is the technical excellence of the service that is being rendered. So if we are saying that the reproductive technology is IVF, we want to understand what is the efficiency level of this IVF. In other words, what technical excellence does it offer? So we should be able to legislate that the technical excellency is at 90% efficiency. And without 90% efficiency of a particular method, we shouldn't be able to use such a method on our population. So that is just a policy that would look at the technical excellence or the quality of the service. The second aspect we have to look at in trying to form a health policy is a licensing and monitoring system to control all practitioners and the premises in which they work. For example, in the medical field, we have an allied health association where they do annual subscription, but also they are licensed so that anyone who is practicing is being monitored or has to get a license from that particular body. So, in forming a health policy, especially for assisted reproductive technologies, we need to have that body that can be able to monitor the practitioners. What is this person's level of practice? We cannot have someone who is unemployed for 2 years come into and just start practicing. Or you have to have a body that can then go and be able to license someone's premises in order to offer such services. For example, the dental body that does licensing for dentists, so that the body is able to understand the type of equipment, the efficiency of equipment that you have, but also how viable your premises are, so that they offer service that is quality. And the third aspect is we will have to look at the legislation to avoid abuse, but also to prevent possible damage. Here, in this case, we're looking at the mother and the child, and outlaw techniques unacceptable in a given cultural setting. And we're saying mechanisms to ensure the adherence by all to ethical and deontological principles. So in this case, we're looking at legislation that then can prompt someone to be skeptical with doing things that are out of ethical context. For example, we were looking at a policy aspect where you can be able to estimate the amount of money an individual should charge, so that it is not very abusive, or also that it is not beyond what the normal is. For example, you have a ceiling for the amount of money that is charged for a particular service, so that then services are not, the individuals are not exploited. But also you should be able to legislate to prevent damage. So in this case, there should be laws that state the type of mother or the type of a child that can be able to undergo some of these assisted reproductive technologies. For example, you may legislate that people who should access such a service are those that do not have certain health conditions that might be dangerous. So those are some of the laws that should be able to help to prevent some of the damages that could be that could arise as a result of assisted reproductive technology. So no one refuses the need to ensure that services offering assisted reproductive technologies adhere to technical excellence. And everyone agrees that technical guidelines should exist and should be thoroughly enforced. So when it comes to legislating about assisted reproductive techniques, and more specifically to ruling in favor of limiting the use of existing technology to certain groups and not to others, or to ban altogether individual methods, views are sometimes totally divergent. So here we are saying that whereas people agree that there need to be laws in terms of trying to make sure there is technical excellence, but when it comes to laws that start limiting the use of this technology to certain type of groups, people start to have different ideas. For example, limiting the use of such particular technology to women who are above the age of 35 or who are below the age of 40. So, for example, when we are seeing the efficiency rate of IVF, we realize that it is age-what, it is tagged to an individual's age. We were able to realize that individuals who were younger possibly had higher chances of becoming fertile than those individuals who took an IVF later in their 40 years. So then, if legislation or realized that there could be an impact on those who take maybe this method at a later age, and definitely they legislated that those beyond the age 40 do not access such a service, then it would involve a lot of divergent views in there. So those are some of the boomerang that come as a result of policy. However, because it is meant for the common good, sometimes policies do not favor everyone. So in countries where legislation is fairly liberal in terms that it is a little equitable, that throughout the country there is possibility that every other person can access such a service. So in liberalization, we're looking at the laws are not definitely very harsh. So usually in this kind of countries, both the physician and the public view legislation with favor. And conversely, where a number of restrictions exist, many complain that legislation impairs their ability to offer proper services. So it is ideal that some of these policies are liberal, meaning that they're a little equitable, so that both the physician and the public can be able to benefit. So the solution seems to be simple: well-defined legislative act setting clear principles and providing for the creation of an authority capable of resolving the myriad of individual problems that invariably arise from applying assisted reproductive techniques. So we are saying that in case some of the restrictions exist and there is complaint between the legislator and the public, the only solution would be that there is a creation of an authority. For example, we have authorities such as the Uganda Doctors Union, something like that, but also we have medical associations in different countries. So it is upon some of these authorities that they can be able to resolve some of these problems, and then these laws are readjusted. So governments play a very significant role in promoting infertility-related policies to provide better access to infertility services and comprehensive support for infertile people. A recent study has shown that economic support policies such as insurance coverage and economic reward policies have a significant positive role in the decline of female infertility prevalence. And in addition, a study has shown that annual career support is linked to higher fertility, while traditional family support is not. Also, higher female labor force participation is linked to higher fertility before GDP is included. Conversely, higher unemployment is correlated with lower fertility levels. So these are studies that have been done, whereas you may realize that these studies have been done in developed countries, because the nature of Africa is that we are definitely following suit into development, like the European countries. Some of these particular studies might apply in our social context, because then some of our societies are urban, and also you very well know that some of our societies are actually adopting what we call Western culture. And because of the Western culture that is being adopted in many of the African societies, the possibility that these same studies will definitely work in Africa is very high. So we are saying here that if an individual is offered an insurance coverage and an economic reward policy is there, then the chances that infertility prevalence is lower is very high, because if someone's fertility is insured, then the chances that they, if in case they are infertile, they will access art services is very high in that regard. So we're also saying that the Wilson Center's maternal health initiative has explored some of the social causes and consequences of infertility and the strategies to address infertility in different contexts. But also we were able to look at some of the social causes and the consequences of infertility in our previous lectures. And we were able to see how we can actually address some of these issues. But what is very key is that you should be able to identify as a scholar or as an academician, but also as a health worker or as a social worker, you should be able to understand the context in your own society. You should be able to look at what could be some of the causes in your own society, and this is pretty good research that you should actually do. You should be able to understand what are some of the social causes of this particular infertility in your society, and it will be relevant if you can be able to address them. So the main important thing is that you are able to have statistics on the infertility, and then you should be able to look at how you can address them. So some of the ways of addressing them are the way we are looking at as below. So the next slides we're trying to understand how we could actually address some of the infertility problems in the society. So we are saying access to infertility treatments varies across regions and healthcare systems. But also we are saying public health policies should aim to improve accessibility for all individuals and couples. And like we're just saying down here, as we said before, that insurance coverage and economic reward policies have a significant role in the decline of female infertility prevalence. So then if we are saying that health policies should aim to improve accessibility, if insurance coverage is high, but also if economic reward policies are in there, then the chances that infertile couples can be able to access uh, assisted reproductive technologies. And that is why we're saying there is need to improve access to infertility treatments and their services. So their availability, access, and quality of interventions to address infertility remains a very big challenge in most countries. And here we're looking at developing countries mostly. The diagnosis and treatment of infertility is often not prioritized in national population and development policies and reproductive health strategies, and are rarely covered through public health financing. If you're just to look at your national budgets or your ministerial budgets for the entire country, or if you just peruse through some of the national development policies and some of the reproductive health policies that are coming up, you'll realize that actually infertility does not cut in, or it does not have any financing source, and therefore it becomes a little hard to work on access, but also to work on the quality of interventions, because then through without funds, the possibility that these issues can be handled becomes an extra mile very hard. Moreover, there is also lack of trained personnel and the necessary equipment and infrastructure, and the currently high costs of treatment are major barriers even for countries that are actively addressing the needs of people with infertility. So, whereas in countries there are issues regarding law or policies that do not exist, but also in some countries that are trying so much to address the needs of these people, there is still no skilled personnel. Or we have very limited skilled personnel, but also we do not have the necessary equipment but and infrastructure. But also the cost of medicine is extremely high, and these are some of the barriers that continuously affect the access. And then we're looking at family planning programs and reproductive health programs. And we're saying these programs educate individuals on contraception and fertility awareness. And the very comprehensive reproductive health programs provide counseling and support for couples that are facing infertility. So it is very important that policies that address family planning programs and economic policies that can fund such programs are upheld by governments, so that then if such policy is passed, and for example, in WHO has a comprehensive reproductive health program, but also they have program guidelines on what kind of services should be offered in a comprehensive reproductive health session. And we very well know that counseling as we discussed earlier on, is one of the very, very important aspects in trying to address people who are facing infertility. So legislations for family planning would be very important. Just we said earlier that insurance coverage and financial implications. that infertility treatments are generally financially burdensome. So public policies that can influence insurance coverage for fertility treatment are very, very important. And I think we just looked at it before that. So policies might differ on coverage for fertility treatments. For example, for IVF and diagnostic tests, expanding insurance coverage can make treatments more accessible. So the policy might vary because of the different types of these treatment that we discussed. For example, for an IVF, it wouldn't be the same for a gift, for a gamete transfer. But also a gamete transfer wouldn't be as easy or as similar as a zygote transfer. So the coverage would differ, but generally the policies should be able to encourage insurance coverage across the country so that access to infertility services, infertility treatment services are very, very high in the country. Then we look at the financial implications that the high costs of infertility treatment can deter couples from seeking help. So it is important that public health policies consider subsidies, grants, or financial assistance programs in order to help. For example, when we're referring to policy, for example, when China wanted to have a population shift, you recall very well the one child policy, and you also recall very well that it is actually male that they preferred, the male to the female, and therefore to people who had a male child. So for any woman that bore a male child, the Chinese government was giving them incentives such as tax holidays and so forth. Whereas for those that had females, they were given liberty sometimes to abort and all this. But these are some of the policies that governments put in regard to the population strategy that they want. And but here we are saying that there is need for subsidies and grants. Possibly, if the cost of IVF is about $1,000, then the government should either come up and say they are covering 50% of the cost, or they should be able to reduce some of the expenditure that the service provider or the practitioner would incur in offering this service. So there is also need to support research and innovation through policy. Policies should be able to encourage research and innovation in fertility treatments. Advances in reproductive technology can improve success rates and reduce costs. So as we are seeing the success rates of the different technologies, we're able to see that some are at 78, some are at 80, and so forth and so on. So what is very important is that government needs to support research and innovation. This can be through funding and policy and so forth, so that there is more innovation that occurs, and then there is improvement of these success rates. So then when we have reduced costs, they would be as a result of people being able to innovate locally. And that's why you would be able to realize that later on, if you looked at the COVID vaccine, when African countries started saying that they are actually developing their own vaccine or their own vaccines, you realize that the cost of COVID vaccines drastically started reducing, and many countries started doing donorship, because at the initial start of COVID, the vaccine was limited to a few countries, and for governments that wanted their citizens to be vaccinated, they paid lump sums of money. They paid very high sums of money. But when governments started to say that they can actually do their own national or local treatment, That is why we're saying here that there would be a very high reduction in the costs, because then when innovation is locally done, that means that the cost of production, the raw material costs, but also the labor definitely reduce. So another important aspect here is there is need to analyze policies internationally, and it is important that comparisons occur, because in other countries, if these policies are analyzed, then it can give you an insight on how you can also approach, especially for countries that are low developing, because they have not been able to implement some of this technology. It is important that they do a benchmark from other countries and try to understand how these countries have done, but also how it has been able to affect them. So some countries have comprehensive fertility coverage as part of their healthcare system, whereas in many of our developing countries, we are still struggling to have such coverage, and our fertility coverage may not be very comprehensive. So the aspect here is that there needs to be policy that can help other countries go and benchmark mainly into what we call effective approaches to fertility coverage. So now we want to look at the second last aspect of any intervention, and that is what we call collaboration and advocacy. And for those who were able to look at health promotion, we looked at an entire aspect of advocacy, and we looked at some of the strategies that include social marketing and so forth. So in here, we're not going to definitely look at advocacy as a whole bit again, but we're just going to run through some of the advocacy messages or some of the statements that or some of the strategies that can help engineer the need for policy on infertility. So we're saying that there is need for collaborative efforts between healthcare providers, advocacy groups, and policymakers, because this is very essential in drafting laws that can help. And advocacy can lead to policy changes that benefit individuals and couples dealing with infertility. So the questions that we should be asking is, what is fertility and why does it matter? And the questions we should be also able to ask at a population level is, how do we measure fertility at the individual and population levels? And we have the beauty is that we have been able to cover all these questions already. We've been able to understand what is fertility, but also why it matters. But also we've been able to understand how we can measure the levels of fertility. So we want to also look at the demographic transition and the fertility decline. So these are some of the key advocacy issues that you should be able to look at. And I think we're able to look at the demographic transition, and also we're able to look at the levels of fertility decline. And then we looked at the causes and the consequences of infertility around the world. And these are advocacy messages. You should be able to understand what are some of the causes of infertility, and subsequently, you should then be able to address some of these issues. But also primary and versus secondary infertility, the biological basis of fertility and infertility, the hormonal regulations of the reproductive system, the female reproductive cycle and ovulation, the male reproductive system and sperm production, which we talked about when we are discussing assisted reproductive technologies. But also, we want to look at aspects of common disorders affecting fertility in women and men, the diagnosis and treatment of infertility. We want to look at the assisted reproductive technologies. What are the types, what are the benefits, and what are the risks? But also the ethical, legal, and social issues in art, alternative options for achieving parenthood, coping with infertility, psychological and emotional aspects, prevention and promotion of fertility. So it is virtually the entire module that we've been covered that actually offers you an advocacy information. And that is why we're saying if you can be able to understand prevention and promotion of fertility, then you should be able to advocate for, for issues of fertility. But also, if you understand coping in infertility, then you should be able to address these particular issues in fertility itself. But also, we're saying lifestyle factors influencing fertility and infertility, environmental and occupational hazards, the genetic factors and inheritance of fertility traits, epigenetic modifications and transgenerational effects on fertility, where we looked at the issues of gamete donations and so forth, the future of fertility and infertility research that we just looked at in terms of policy. Then the emerging technologies and innovations in reproductive medicine, personalized medicine, and precision fertility. So in this advocacy, there are quite a lot of particular aspects of fertility and infertility that you have to look at. And that is why we're just giving them a very short mention here, because then we have either covered majority of them or some maybe are not very much applicable in our African setting. And you can be able to see there is artificial intelligence and machine learning applications in fertility analysis, the stem cells and regenerative medicine for fertility restoration, gene editing and gene therapy is possibly what we have in Africa. Then nanotechnology and biomedical engineering for fertility monitoring and delivery, synthetic biology and biofabrication for creating artificial gametes or organs. So these are mainly aspects of advocacy that we have to continuously advocate for. But also we need collaborations, or we need partnerships with either government, with either private entities, in order to achieve these levels that might be very prominent in developing nations. And lastly, in regards to public health policy and infertility, I want us to look at the aspect of ethics, because it is a very it is a very dynamic issue, but it is also an issue of context among societies. First of all, in Africa, one, because of our cultural setting, two, but also because of our religious backgrounds. The issue of ethics is very important in regarding artificial reproductive technologies. So it is an issue that I want us to tackle as our last bit in here. And there we're saying that there are three ethical principles that provide an ethical basis for art. One, the principle of liberty. Liberty, like we said, that policy should be liberal, meaning that an individual has a choice to make, either to access an assisted reproductive technology or not. Two is the principle of utility, meaning that an individual has an access to go and utilize this particular service. And then three is the principle of justice. Justice meaning that the service being offered is the right one and to the right basis. So the medical ethics are based on the moral, religious, and philosophical ideas and principles of the society, and they are influenced by economic policies and law. This creates tension between the principles of justice and utility, which can result in disparity in availability and access to art services between the rich and the poor. For example, we are saying that these particular ethics are influenced by economic policies, So again, like we said earlier on, whereas there is a principle of justice and utility that anyone should be able to utilize these things, but also we are saying that because it is being influenced by economics and policies and laws, there are laws that may be able to deter people of a certain group or a group of people from accessing such services for whatever reason that the law could state. So ethical and legal issues vary between countries and with religious beliefs. Every person also has their own individual opinion, which further complicates this matter regarding ethics. Even if a couple conceive using their own sperm and eggs, the creation of life outside of the body is a momentous act that sparks strong opinion and sentiment. So the aspect here is that whereas the art or this technology may it use an individual's own reproductive gametes. For example, say a woman who might be infertile, they pick the eggs and then they pick another man's sperm, uh, whereas they may be using their own natural gametes. The mere fact that the society believes that creation cannot take a place outside an individual. It should be able to take place inside, not in a petri dish, like we said earlier on. Makes it very hard, or it causes a very momentous, strong opinion and sentiment about the use of these assisted reproductive technologies. So if you add donor gametes or a surrogate mother to the equation, the situation becomes even more complex because like we said with the issues of surrogate mothers, and the donor gametes, they are donating unto you one of the gametes. So this adds fuel to the matter. Whereas at first you're first allowing creation to take place out of a body, now you are again adding another person to create for you, and you call it your own. So these are some of the key issues that affect ethical conditions. So we want to just give you an example of the ethical but also policies in some of the countries regarding the use of artificial reproductive technology. So these are examples of ethical. Let me just write here. Examples. These are here. We're looking at examples of ethical uh, policies, ethical policies on artificial, on assisted reproductive technology here. So one, we're looking at using donor sperm or eggs. So law guarantees anonymity of donors in Greece, for example, but this is no longer allowed in the UK. So, for example, if you're donating a sperm or an egg, the law in Greece does not allow them to declare the name or the details of the donor. But we're saying here that in the UK it is allowed. So that is one of the policy or ethical considerations in donating gametes. Two, embryo development period. In many countries, embryos are allowed to develop for a number of days to enable selection of the healthiest one for implantation. But in some countries, only early embryos can be implanted. You remember when we were discussing implantment in IVF, and we said that sometimes the embryo takes 4 or 24 hours in some places so that they can be able to identify the one that has a healthy growth. And that is why we're saying That is a policy in a country here. 2 is paying surrogates. Commercial surrogacy is not permitted in many countries, but it is completely legal in India. So in India, surrogates are paid, whereas in some countries it is not. So the views regarding when life begins, the Catholic Church believes life begins at conception and only allows fertilization of eggs that will definitely be used, meaning all viable embryos have to be implanted. Other individuals believe life does not really start until a few weeks later and are content with selecting only the healthy embryos for implantation and discarding the rest. So here you're looking at the Catholic Church believes that life begins at conception. So their thinking is that when 4 or 5 embryos are fertilized, then all those should be implanted because they are all life. However, some individuals believe that life starts relatively after, and therefore for them, selecting embryos, the ones that are healthy, is the choice that they make. Then the use of stored sperm or embryos after a partner's death also has a policy. So in Iceland, frozen sperm are destroyed if a male partner dies, while in Belgium, sperm can be obtained for future treatment if written permission is given. The embryo storage time. In Spain and Canada, embryos can be stored for an unlimited period, whereas in Brazil, they can only be stored for 3 years. Embryo selection processes and genetic screening. Genetic screening prior to implantation is completely banned in some countries, but only subject to strict regulations in others. Then another policy there looks at maximum number of embryos implanted. In many countries, there are strict single embryo transfer policies, whereas the number implanted is left to the physician's discretion in others. So that was just a brief of some of the ethical considerations, but also some of the policies that guide assisted reproductive technologies in different countries. And that virtually concludes our aspect of fertility. So the entire module, if you went and looked at our course unit, we virtually have covered all the aspects that we believed that we should cover. And this definitely ends our cover for that particular module in there. Unless we have any other questions, any comments from wherever we started to discuss this particular module until now, the floor is